Dr. George Shenouda, welcome to this special interview. And let me start by offering my congratulations to you for being one of the 8 laureates of our first cohort inducted into the Academy of Exemplary Physicians. So welcome.
Thank you so much, Dr. Fuks, for inviting me to come today for this interview. It's an additional recognition of the performance as a physician in this great institution like Faculty of Medicine at McGill. It is a motivation to do better, and I recognize wholeheartedly how much McGill is careful and attentive to encourage academia at all levels. So thank you for having me, and thank you for having given me the opportunity of the laureate.
Thank you. It's a real pleasure for me to be speaking with you. As you know, the Academy was created in order to recognize clinical excellence, excellence as a doctor. McGill has long been attentive to the research accomplishments of all our colleagues and to their teaching contributions. But what do you think it means to you as a physician to have this new honor of being an exemplary doctor? What does it mean to you personally and maybe even emotionally?
Emotionally, it's like a dream beyond the dream. It's something that I never thought I would ever experience in my career. It came as a surprise, honestly, and I didn't expect any recognition that big and that prestigious. It reinforces a basic knowledge that I learned in an instinctive way. I discovered with the laureates and the recognition that it is true. There is no great educator, there is no great researcher if this person is not a great clinician. Because we learn from our patients. We have great questions and ideas from our experience as clinician. Now, there should be the background that will encourage the translation of the clinical experience into clinical trials, into basic research, and being able to transmit the information to the new generation that has the opportunity now to learn their own way, new ways to deal with the problems. So I think the clinician is at the basis of the educator, is at the basis of the researcher. They cannot be separated and segregated. One type of clinician and doesn't be interested in research. So I got the opportunity to have my the path that was chosen for me, or I chose it myself, was conducive for this. I don't know if you remember, I was a student in the experimental medicine program as a PhD.
Yes.
And at that time, I had the choice of going into clinical practice immediately as a resident or to do a PhD. And I was privileged and blessed to have mentors, like one of them, David Thompson, Phil Gold, yourself. You were there and you taught me in the class, I remember quite well. So I got this introduction into academia and clinical research. And then when I came to practice medicine as a radiation oncologist, all of this came back to me. And opened my eyes to the real questions in clinical practice. Is it good or can we do better?
Okay.
And then my previous basic research and PhD helped me to take it further. And it has always been like, as an educator also, I found that teaching is vital, is a responsibility. And if I have given the opportunity, I should use it to the best.
So, George, you see all 3 aspects of your work all connected, right?
Absolutely.
The research, the teaching, and the clinical work.
Yes.
Tell us a little bit, for those who may not know your background, what work do you do? What kind of clinical work do you do? What does it involve? And maybe tell us what a day of work looks like to you. What is it that you do every day?
That's correct. So I am a radiation oncologist. So we are a team of 15 to 16 radiation oncologists, and we have been working together for now. I have been in the group for about 35 years. So it's a privilege to have a so beautiful and harmonious group, and that allows the flourishing of people with different orientation and different direction in their clinical as well as academic endeavors. So a day for me means like I arrive at work around 8 o'clock in the morning. I have some paperwork to finish to make sure that I'm not missing any important information. And then the clinic starts. And the clinic for me consists of 3 types of activities. Or when there are patients, they're either new patient coming for consultation for a new diagnosis or recurrent disease. There is patient who had been treated and come for a follow-up. And there are patients who are undergoing treatment on a daily basis. So 3 groups of patients, new consult, follow-ups, and intra-treat. And that takes about from 9 o'clock till 5 o'clock in the afternoon with a small break in between. Apart the clinical encounters with the patient, there is a clinical activity which is preparing the treatment, planning the treatment, looking at all the radiological, pathological staging of the patient, and creating the plan for the dosimetry to create the treatment for the patient. So this takes, like, I am lucky because I like what I'm doing, and I'm doing head and neck oncology, and I used to do also CNS oncology. So I do have patients who will require planning for about 3 hours, maybe 4 hours, and this is usually done after the regular time of the clinics, because we serve the patient when they are here, but the planning is done evenings. Not every day, but not infrequently during the week.
Right. Okay.
And this will be given to a dosimetrist who will do a planning of the dose to avoid normal structure and to focus the treatment on the target organs.
Right.
And in head and neck, you can imagine how many organs need to be avoided, and the target is sitting in the middle of a lot of normal tissues.
Right.
So it takes a lot of planning, and then we start to deliver the treatment. The treatment is given on a daily basis, Monday to Friday, and it depends how many weeks, 5, 6, 7 weeks, during which I meet the patient once with the team. And that's what I also want to emphasize is important to create teams of people who have common interest and complementary skills and knowledge to help the patient, because I am the doctor, but I discovered, and I'm definitely grateful that we have excellent dietitian, excellent speech and language pathologists, excellent nurses, social workers, and the team is really complete. And that's what the patient always, when they finish treatment, they say, Dr. Shenouda, you have a great team. So the team creation is basic into the clinical practice. And that's we see the patient together. We have one message, harmonious one, not one saying something and the other one contradicting. And the patient feels confident that they are taken care by a team, not one individual. Should this person not be present, then they feel unsafe.
Right.
So that's what a day looks like. We have time for vacation, as usual, and time to go to conferences. And also there is a priority for activities like teaching.
Yes.
Is given always a priority. There is no limit. If we want to teach, that to be like always granted, and so on.
in these busy days, what opportunity do you have for direct interaction with the patients?
I would say almost all the time. Like I have very rare activities. Like I said, the planning activity is done at the end of the day,
Right.
when the patient leaves, not while they are in the clinic. And it's usually between 4 to 5 o'clock in the afternoon. The planning is being done later after or during weekends sometimes. Yeah.
So in your particular discipline, radiation oncology, you're often dealing with patients who have diseases that are not easy to deal with for the patient and the family. What have you learned as a means of helping the patients cope with 5, 6, 7 weeks of treatments every day, the side effects that come with that? What have you learned about how to work with patients and families to mitigate all those unwanted effects?
Yeah, which is definitely a very important point, as we know that patients with cancer are always very concerned, afraid, and are waiting for the worst to happen.
Yes.
So my approach is to prepare the patients for the reality of what they are going to experience, and tell them that we will always be there. Give them this reassurance that they will not be left alone or isolated. Isolation is one of the worst fear for any patient, but more so in oncology, where they feel that when they are not well, people will not be interested to work with them, and they will be left alone. So the importance of reassuring them and demonstrating it by facts, by action, by acts, to be for them and to be with them, they appreciate it and they feel it immediately. And this makes going through significant toxicity, like head and neck radiation, is special because that's where we eat, swallow, talk, and the skin get burnt, and they go through severe complication.
Yes.
And when the patient feels that they are supported and they have been given the truth from the very beginning, and they know, first I tell them first week will be easy, but then it will get worse, and they expect time-wise and management-wise, step by step, giving them also the opportunity to say, let's say I see the patient once a week while they're on treatment. However, in between, you can come anytime.
Yes.
If there is a question, and give phone numbers and give adequate connections, so then they are not left on their own without help.
Right. It sounds like because of the illness and sometimes the rigor of the treatment, there's a fear of abandonment, is what I hear you saying.
Yes, exactly. The feeling of abandonment is in any patient, but more so in oncology patient, because they know that things are not always going to be okay.
Right, right. And you also warned them in advance, so there's also the element of being honest and forthright with patients. Right?
Full disclosure.
Yes.
Full disclosure and transparency. Recognizing the impact of the treatment, not diminishing it or neglecting the details. And I think the patients appreciate that we listen to them. We sit down and we take the time, we meet as a team, and they don't leave till they say, oh, I have no other questions. I have no other concerns, and if so, I will come back and tell you about it. I think key is listening.
Yes.
And being attentive listener.
Yes.
To listen and to really follow the connection of the words that have been said. And ask them about the real concern, because the patient may be concerned about the physical problems,
Yes.
reaction, pain, and so on. But they can also be worried about the kids at school. They can be worried about their husband and their family. And that's where the team comes, where we can help the patient from different angles. A social worker is there, a psychosocial service is present. So we can take an integral care, not only a partial medical care that is delivered and then that's it. And I do appreciate that very much.
Yes. So you pointed out the importance of not only listening, you said attentive listening.
Yes.
What does it mean to you, attentive listening, is one question. And the other is, where did you learn to do it effectively?
Okay, attentive listening for me is to listen and to have contact. To listen and to have contact with the patient, looking at the patient, being at the same level, and repeating sometimes what they say, meaning that I retain what you said and I know what you mean, and ask questions if I don't understand clearly what they say. So I find also a smile makes it easy for them to open up.
Okay.
They need a certain allowing them to talk. And when you allow them to talk, they talk.
Yes.
And when they see that you are understanding and responding, they give you even more.
So I hear you say that listening is an invitation for the patient to speak.
Absolutely.
Right? It allows them, it permits them to speak. So in your field, like any field, there are good days and there are more difficult days.
Yes.
And I imagine you come home sometimes saying, today was a good day. What does that mean to you? What does it mean to say, today was a good day at work?
When exactly the connection with the patient went well. And it doesn't matter. And I give you an example of situation when I can go back home and say the day was okay, well. When there had been a patient who passed from the disease and the family comes back and says thank you.
Okay.
And they say that although the patient died, but he was appreciative of the care of the team. So you see the contradiction of knowing somebody passing, and at the same time the emotional reward of having done something for this patient. We will never cure 100% of the patient.
No, of course.
If we start with this premise, we can be able to even enjoy even the hardest times. What a bad day is when I wanted to help the patient and I find difficulties in my environment to provide the help that is needed when is needed. We have waiting lists. We have delays in investigation. You request a consultation. It takes time. We request a scan. It takes time. And to me, cancer patients should not wait. Cancer patients should be treated immediately as fast as possible. And that's where I feel the frustration, where I am willing but not able to.
Right.
Yeah.
So it's interesting that the benefits you feel when you feel good about the work is your connection with patients. Whether things have gone well or not, there's the connection. The frustration doesn't come from the patient or family. It comes from the context, the environment, and the frustrations of the daily work.
Exactly.
Yeah. And in your many years of work, how have things changed? Is it, have patients changed? Have families changed? Has the environment, technology has certainly changed.
That's for sure.
The way you work.
Yeah.
What things that you remember over a span of 35 years have changed, and what things are better and which things are less good?
Okay, so from the material point of view, technology has made a major difference in the way we practice. And definitely is more precise, is more accurate, more capable of doing things that we were not able to do before. The complexity of a case is definitely significantly more than it used to be. A pathology report used to be 2-3 lines. Now it's 2-3 pages. And the details and the importance of every word, every line in the patient documentation makes definitely the evaluation more granular, more important, and more profound. The patient, I don't think there is a major change in the patient, at least in their attitude, the way they interact haven't changed. But what I found, and your question is very, very opened my mind to, the change happened in me more than happened in my environment or in the patients. It's me who start to see as a privilege and look at what I'm doing with a different perspective, not only to treat the patient, but given the opportunity to heal the patient. Because we know that the patient can be treated, can be cured, but they can still be traumatized, can still carry with them all the pain of diagnosis and the treatment complication and all what comes with it. What I can appreciate now that I have this additional step of trying to help them accept it and live with it in an objective way by telling them in advance what to expect and to listen to them. And honestly, after many years, like you have a certain connection with patients, and they tell you, Shenouda, like, I know that I have been treated well and I'm cured, but I would like still to come and see you.
Really?
Yeah. And definitely this is, for me, is a success of treatment when the patient is cured, but also accepting life and happy with it and going on.
So you see two different dimensions: treating the illness and perhaps controlling it or curing it. And yet another element of healing for the person. And how do those connect to each other?
I think healing is very important because that's all what we are, like a primary objective is to control the cancer, get rid of it, and have an uncomplicated cure. That's the objective of in what we're doing.
Right.
But I have seen situation where it didn't work, and the patient has a recurrence, or ultimately sometimes the patient definitely, some of them die. And I can see the healing in the family, and I can see the healing in the patient who is announced to him or her that the tumor has recurred. And at that time, you feel that there is certain acceptance, certain resilience to accept and to continue the process. And that's where the like winning on the cancer is one thing, and winning the person healing is a different level. And sometimes one can be surprised how they can be totally discordant.
Really?
Yeah.
Are there particular patients and stories you can share with us that stand out in your memory as significant in your own evolution and your own maturation as a physician that helped you understand many of these things?
Yeah, that's like there are many of them, and the one that remains like clear in my mind is the patient who unfortunately died. A young woman with melanoma, And she fought as much as she could, and we tried everything that's possible. We always were present for her and followed her closely. And what I got after her passing from the family, made like words about how she felt, that she was in peace, that she was never sour or angry against her sickness, and when she passed in a very peaceful way.
Okay.
And she mentioned that to her family, and she asked them to come and talk to me after she passed. So that was again a situation where, like, I always remember that more important than the physical cure is the spiritual and emotional connection with the patient.
So sometimes if a patient has finished treatment and they say, I would like to come and see you, do they come and visit you and you say, it's okay to come once in a while?
Absolutely. The follow-up is very important.
Okay.
And this is something that is sometimes I'm criticized about it. I have patients I have treated 30 years ago.
Wow.
And they still come to see me. And definitely the medical component of it is important, because radiation-induced malignancy can happen years after the treatment is finished. And the younger the patient at the time of treatment, the higher the risk of radiation-induced malignancy to take place. So I see them, and I have patients who, like, I tell them, I think this is enough. You don't have to come back. Say, no, Dr. Shenouda, I want to come back. And I give them appointments sometimes in a year, in 2 years, and they come back. So this connection for me is a reward that no reward can replace.
Yes, of
when
course.
you have this human connection with the patient.
Of course.
Yeah.
You mentioned earlier in our discussion that you learned many of these things. I think you used the word instinctively or intuitively.
Yeah.
What do you look back on the important elements of your own learning experience? Was it people and clinicians you met or worked with? And even early on, you said you had to make a choice between continuing in a pure research career and shifting to medicine. What made your thinking evolve at that point to make the choice that you're...
These are great mentors I had the chance to encounter and to shape my training, both at the basic research one and at the clinical. Like, I have worked with clinicians who are superb medical physicians, medical doctors, and human beings. And I saw the compassion, I saw the involvement of the physician in the patient's care, and in a multidimensional way. Was not only like clinical, see patient, do the job, and that's it. No, there was a continuous long-term connection. And the instinctively, I think I can say it's mainly through encountering and facing a lot of pain in patients that I have encountered. They have a lot of side effects. They have a lot of difficulty with their disease as well. And when you see pain and you see patient reacting to it, it cannot leave me neutral.
Right.
It does. And when I look at them and I see, would I have the same courage and persistence to go through what they are going through? And the days where I feel weak and tired, I say, look at this in front of you, how people are resilient and tenacious, and respect the healing that they have as an objective, and they go after it. So I think this is part of shaping the physician by the patient.
Yes, of course.
And learning from them their attitude towards how to heal.
So in one way, you're saying, George, that we ourselves are somewhat healed by watching our patients
Absolutely.
be healed in some way.
Yeah. And
So we
learn how
learn-
to deal with because like I have also been patient
Sure.
for different reasons. And when things are tough and hard and there is pain and there is doubt and there is concern, I look back and I see my patients,
Really.
how they went through that, and it gives me the courage to go on.
How do you involve and bring students and residents into your practice? And how do you try and transmit some of these concepts to them in the daily work?
Yeah, so there are some radiation oncology visibility in the curriculum, which is limited compared to oncology being like an important specialty in medicine in general. However, I was lucky to work with Boudreau and the dean to create a certain undergraduate oncology program. And this, I think, was an eye-opener and brought some light on radiation oncology and oncology in general. So that was one of the teaching in the class, and get the students to see patients and interact with them. The other one is like showing the residents how I am dealing, how I am working,
Okay.
and being there for them, asking how they feel, always reacting and asking their experience, because some of them have difficult experience seeing patient with cancer.
Sure.
They are in the beginning of their training. They have not got experience from before, and they find themselves in front of situation that can be overwhelming. And this, like, I think sometimes is underestimated in the way we educate or give example to our residents, is to think that they are able to handle all of them the same situation, the same way, at best way, which I think is a misunderstanding and misperception of reality. They can perform excellent, but they can be totally overwhelmed. And we need to be careful to identify this situation where the resident or the medical student is unable to deal with the situation. And this may reflect on their performance.
Yes.
And we need to ask them how they feel about it. Not only what did you do with the patient and if the work is done and everything is fine, and stop there, but how did you feel meeting this patient? How was the emotional and feeling that you have after encountering patients?
Okay. So that's a normal part of your discussion with a resident or student, is not only what were the dosimetries,
Exactly.
and not only how did the patient feel, but how do you feel?
It's important to give them the opportunity to mention it, because they may be shy to say, oh, that was too much. I felt uncomfortable. Because they also, I think, part of all human nature, that we are able to. We are good to do it, and we are not afraid. We are not scared. But sometimes, reality is that some situation can be scary, can be very sad, can be very traumatizing. And if we don't allow them to say it, they will retract. They will not say it, but it will mark them.
I imagine you do the same with patients, right?
Exactly. Yeah.
And so you see a parallel then between teaching and clinical care.
Absolutely. Absolutely.
And the two are somehow related to each other.
Related.
Okay.
And I think the tools that we use in one is the same as we use in the other one, is understanding, is listening, is empathy. And I always said, each patient is unique.
Yes.
Is unique, and like what I have in my heart is, how can I do the best for this patient?
Yes.
But not only physically, but also like supporting. Definitely, there are patients who have different needs to be supported. Some are dealing very well with it, but some are not at all doing well. So I need also to gauge my energy for those who require it more than others.
Right.
And that's again the experience of seeing a lot of patients. One get this sense of how much needed is needed.
So it's interesting, in both cases you say you have to go beyond the first step. It's not only the patient's dosimetry and illness, but that patient's healing as a person. And for students, it's not only do they know the facts, but can they cope emotionally with the situation in front of them?
Absolutely.
And so in both cases, the lesson you learned and you're teaching us is go the extra step, go beyond the usual limits.
Because that's a step that makes a difference.
Patients certainly appreciate it, you tell me. Right?
A lot.
And students?
And students. And I have students who came into radiation oncology after some interaction in their undergraduate, and some residents who chose to do head and neck oncology after, because they enjoyed the subspecialty and the interaction. So I'm blessed in this aspect, and it only gives me more to do. Of
course, more to continue.
Yeah.
And so in that sense, you're a very strong role model for the students and residents who say, I want to do what you do, right? And
exactly.
It becomes a continuity.
Yeah. The beauty is that it's done without like being aware of doing it. It comes natural. And that's why it is spontaneous, and that's why it's not calculated and measured.
Yes.
It's like I feel that this is how it should be.
So the word I hear is it's authentic, it's natural, right?
Could be, yeah.
And it works for you.
Yeah.
What lessons would you like to transmit to incoming medical students? Some of them are saying what you noticed. There's a constraint on resources. It's not easy to get things done. Some of them are saying, is this still an attractive way to live and work, to be a physician? What would you say to students who are considering a career in medicine? And would you encourage them?
I would encourage them, because like I definitely would go back and do the same thing again if I have to choose.
Mm-hmm.
And I encourage them because there is what we said all the time, there is something beyond the technical and material aspect of the practice and the connection with the patient. And this privilege of being able to intervene, change and modulate and have an impact on a human life is a gift that is special. And I think one feel the beauty of it when we love it, when we do it and we find that this is bringing satisfaction.
Yes.
And bringing like a smile on a face who is suffering, who can smile with you and can be present and share the feeling with you. Medicine is not about winning all the time. Is like you have to, and that's unfortunately what we don't learn in medical school. The medical school will teach you, you do this and this and this, you get a good response. You cure the patient. Right? But the points, like I said, when I encountered pain, that's where I learned. That when I encountered failures, that I learned. And my advice for them is not to be too harsh on themselves when there is a failure, because there is always a human component of any activity we do. And part of medicine is sometimes you do the best you can. You can spare no effort and energy, yet you will not gain at the end. And with this in mind, I think one can overcome the imperfection of the environment
Right.
in which we work, in which we deal with on a daily basis, the limitation. We have also to be proactive in improving our limitation, not to complain about it and do nothing. We need to be a little bit of an advocate for our patients, and not to let things go out of control. It's a limited space to maneuver in, but every step counts. And if I can help the patient get an earlier scan and get a faster treatment, I think one patient at a time makes a difference on the long term.
Yeah. So, George, thank you for sharing these wonderful ideas and concepts of a journey that started more than 35 years ago, and for sharing both the pain and the joy with us. And I thank you for helping our all of us and our residents and students appreciate what an exemplary physician can do and be. Thank you very much.
And I appreciate very much the opportunity to come here today to share with you, and to you allowed me to say what I have in my heart and what I had been through, and it's in itself, it's a healing process for me. So thank you very much, Abe.
Thank you.
Thank you.